Felix fam. I'll be your moderator today. I just wanted to first thank Mary Ford for putting together this wonderful gathering today, brought to you by Miracle Living and all the partners here in the back helping in the background to make things work very smoothly. Some quick introductions. I wanted to introduce our panelists, starting with Dr. James McKinnell. So Dr. James McKinnell is a board-certified internal medicine and infectious disease physician. He received his undergraduate degree at Stanford University and earned his medical degree at Columbia University. He conducted his internship and residency training at Harvard UCLA, and he also completed his fellowship in infectious diseases at University of Alabama, Birmingham. His clinical research focuses on epidemiology, management of chronic and resistant infections with a special interest in global infectious disease issues. Having more than 15 years of diverse experience as an infectious disease physician and internal medicine specialist, Dr. McKinnell cooperates with many of his fellow doctors. He is an infectious disease research specialist in the Malefchik-Rand Medical Group and is the physician chair of the Young Physician and Professional Associations. We also have Dr. Damian Goldberg, and he is a member of the Torrance Memorial Medical Hospital since 2005. He received his board certification by the American Academy of Ophthalmology in 2006. As a South Bay native, Dr. Goldberg obtained his BS at Emory University in Georgia before attending Georgetown University of Medicine in Washington, D.C. His residency in ophthalmology remained at Georgetown Washington Hospital Center in Washington, D.C., followed by his fellowship in cornea, cataract, and external diseases at UT Southwestern in Dallas, Texas. Dr. Goldberg currently works as an eye physician and surgeon in private practice at Wollaston and Goldberg Eye Associates, where he performs routine eye exams as well as surgically manages cataracts, cornea, and LASIK patients. Dr. Goldberg presently serves as the chairman of ophthalmology subsection at Torrance Memorial and serves on other committees at the hospital. Outside of his work, he enjoys his family, activities with his family, surfing, skiing, jogging, and traveling. And finally, we have Kristen Hung. Kristen Hung has served as a registered dietitian here at Torrance Memorial since 2016. She completed her dietetic training through the VA Greater Los Angeles healthcare system. She completed her Bachelor's of Science in Nutritional Science at UC Berkeley and earned a Master's in Public Health from UCLA. Kristen was born and raised and currently resides in the South Bay. She enjoys serving her community through nutritional care at Torrance Memorial and promotes health for both patients and employees. Outside of work, she is busy caring for 2 daughters and enjoys Zumba. All right. So just to kick off our presentation, again, I'm Felix Pham. I'm the pharmacy clinical supervisor here at Torrance Memorial Medical Center. I've been here for about 8 years, since 2016. I serve as the pharmacy clinical supervisor for the inpatient department. I graduated at UCLA in 2005 with a bachelor's in biochemistry and finished my doctorate in pharmacy in 2010 at UC San Francisco. Today we're going to go over drug and food basic allergies. We're going to go over seasonal allergies. We're going to dive into penicillin allergies as a focus, and then provide the public with some take-home points regarding drug, food, and seasonal allergies that they can, share with their family, friends, and their healthcare team. So just to emphasize some of the verbiage that we're going to or de-emphasize some of the verbiage that we're going to go over. This is just for your reference. You do have a handout where we maybe make mention of some of these terms, but don't be afraid if it sounds like a little bit over your head. Do stop us and ask more questions. Don't focus too much on the technical terminology. Just some continued reference definitions for you as we go through some of our lecture slides. So some quick stats. I'm a numbers guy myself, and this kind of highlights, the broad, array of how allergies affect us all. And 1 in 4 children do have some sort of allergic condition that they're dealing with. We'll be addressing some of these things today, and then try to dive into a lot of what might be a little bit more unknown to the public. So I wanted to start off our lecture series by introducing Kristen Hung to the podium to talk about food allergy basics.
Thank you, Felix, and good evening, everyone, both here in person and those joining us online. We're glad that you joined us today, and let's go ahead and start by talking about food allergies. Now, did you know that according to the National Institute of Allergies and Infectious Disease, about 32 million Americans, or approximately 8% of children and 11% of adults in the U.S., are affected by food allergies? That's equivalent to about 1 in 13 children and 1 in 9 adults. There are also about 170 foods that have been reported to cause allergic reactions. So with so many people being affected by food allergies and so many different foods that can be related to allergic reactions, it's important for us to understand a little bit about food allergies and also how to manage them. Let's begin by discussing the 9 major food allergens. It's estimated that approximately 90% of allergic reactions in the U.S. are related to one of these 9 major food allergens. And these include eggs, milk, tree nuts, soybeans, sesame, wheat, peanuts, crustacean shellfish, and fish.
Yeah, come on.
It's important to distinguish between an actual food allergy versus an intolerance. Improper classification can lead to unnecessary restriction of the diet and could lead to deficits in nutritional balance. So in the inpatient setting, in the hospital setting, we see this often where people have allergies listed in their medical records that are not true allergies. And this comes to create a problem when they call down and they try to ask for something like cake, and they're not allowed to order that because of the allergy listed for dairy, when really what they have is lactose intolerance. So really properly classifying an allergy versus intolerance is important to avoid these types of unnecessary restrictions. Now, food allergies involve an immune system response that occurs immediately or soon after a person eats a specific food. The symptoms can be mild to life-threatening, but usually involve the skin, respiratory system, digestive system, or the heart. The body produces IgE antibodies to fight the allergen, triggering a protective response. In contrast, a food intolerance or sensitivity does not trigger the immune system. The symptoms are not life-threatening, but may have similar symptoms or presentations to a food allergy. Usually this is related to our body's difficulty with digesting a particular food, which can result in a lot of symptoms like gas, bloating, stomach ache, or diarrhea, and can be related to things like food sensitivity to additives or to IBS, which is irritable bowel syndrome, or the absence of certain enzymes. Let's look at the example of wheat allergy versus celiac disease versus gluten intolerance. Now, with a wheat allergy, we're having an irregular immune response to at least one protein that's found in wheat. And those with wheat allergies have to avoid eating wheat or any products that contain wheat, but they can eat other grains like buckwheat or millet, quinoa, oat, rice, teff, etc. With celiac disease, we're having an autoimmune response to gluten, which is a family of proteins that's found in certain grains, including wheat, but also barley and rye. So celiac disease affects approximately 1% of the US population, and over time, this can actually cause damage to the small intestine's lining, and that can cause malabsorption. So often there's symptoms like diarrhea, fatigue, weight loss, bloating, anemia, and when in children, this can affect their growth and development. So those with celiac disease must follow a strict gluten-free diet, including avoidance of any foods that would have gluten added, like soy sauce, certain dressings or gravies, certain spice blends, or even some processed meats. Now, gluten intolerance is estimated to affect about 6% of the population and is also referred to as non-celiac gluten sensitivity. Now, this is characterized by experiencing certain symptoms after ingestion of gluten, such as bloating, gassiness, fatigue, depression, anxiety, headache, joint pain, nausea, vomiting, and skin rash. Now, the causes are a little bit more unclear for this, but could be related to improper absorption of carbohydrates or fermentation in the gut, or to wheat affecting the lining of the digestive tract. There really is no clear diagnostic test for this type of gluten intolerance. Let's look at dairy allergy versus lactose intolerance. Now, this is one of the most common intolerances that we do see. And with dairy allergy, again, we're having an immune system reaction to milk or any kind of milk products. So those with dairy allergies must avoid all dairy or eating any products that do contain milk. For lactose intolerance, this occurs when we have a reduced lactase activity in the brush border of the small intestines. Now, lactase is an enzyme that usually helps digest a sugar called lactose that's in milk products. And symptoms usually include nausea, cramps, bloating, gas, diarrhea, and most people can tolerate some amount of lactose with minimal to no symptoms. So this one is a dose-dependent response, and treatment usually focuses on decreasing our lactose intake rather than totally or completely eliminating it. Now let's transition to talking about tips for living with food allergies or supporting someone who you know who is living with food allergies. The first tip is to learn to identify allergens on food labels. Now, this is very important as the only way to really prevent a food allergy reaction is to avoid the problem food. There was two laws that were created to help consumers to better identify food allergens, and these laws stipulate that the common allergens must be called out in one of the following ways. First, they can be called by their common name in the ingredient list. They can also be labeled by using the word contains, followed by the name of the food allergen, or it can be in the ingredient list in parentheses with the common form of the food allergen listed. So for example, if it says albumin, then it would have in parentheses eggs. There's also some voluntary labeling, so these ones are not required, but manufacturers can put these on their labeling to help consumers, and those include statements like may contain, processed in a facility that also processes, or made on equipment with. Now, if you don't see these types of disclaimers or labeling on your food products, that doesn't mean that your food has not possibly come in contact with an allergen. So if you do have a severe allergy, you do want to contact the manufacturer and ask them if there's any chance that your allergen might have come in contact with the food that you're eating, and what are their practices around managing food allergens. Now, there's also really, it's a good idea to just become familiar with the food your allergen often appears in and some less common names for your allergen. And I wouldn't recommend buying any ingredients that don't have any products that don't have ingredient lists, and also imported products, because labeling laws in other countries differ from our laws, and even though they are supposed to follow our domestic laws, when they're imported, some of those products don't. So to be safe, try to avoid unlabeled or imported products. The second tip is to avoid cross-contact. Now, this is important, especially if one member of your family has an allergy while other members don't. And so these are some tips for avoiding cross-contact. Really, washing your hands is a great way to help prevent this cross-contamination, and also changing gloves during food preparation, cleaning, sanitizing surfaces before and after prep, using clean kitchen tools. Make sure you have dedicated cutting boards if you do have a severe allergy, designating special food preparation or storage areas, using color labels to color code and label items and separate. And when you are washing dishes, clean, sanitize, and then make sure you're air drying the dishes rather than towel drying, because that can also cross-contaminate. A third tip is to make sure you're dining out safely. Now, when you are choosing restaurants, you could consider avoiding places that there would be an increased risk of cross-contamination. So things like buffets, ice cream parlors, and bake shops, those are often, unfortunately, some of the ones that there's a greater risk for cross-contamination. So choosing also chain restaurants can be a good idea because often the recipes need to be standardized so you can know what ingredients are going in. Consider dining out when the restaurant is also less busy so your server has time and the cooks also have time to make sure that your allergen is not being included in the food. Call ahead if you're not sure if they can accommodate your food allergy, and also make sure you're informing all your restaurant staff of the allergy. Another tip is to choose simple dishes. So the more complex your dish gets, the more likely there could be some cross-contamination there. And you also want to avoid fried foods, not only for health, but also because the oil can cross-contaminate your food as well. And there's also on the Food Allergy Research and Education website, there are these printable chef cards that you can give to your server. There's one shown on the screen here, and you can actually write down what your food allergy is and what your reaction is, just to let the servers know.
Yeah.
Lastly, be prepared. So if you do know that you have a severe food allergy, make sure that you're always carrying your emergency epinephrine. They recommend actually having 2 doses on you. Always wear your medical alert bracelet to alert anybody, servers, and also, if an event should happen, that people would know that you do have that allergy. Bring your own meals and snacks when appropriate. Notify key people. Make sure you're sharing your plan. And if you're having trouble finding foods that you can eat with a food allergy or multiple food intolerances, then consider seeking support from a registered dietitian nutritionist. It can be difficult and challenging to live with food allergies, but with proper preparation and support, it can be done. So thank you very much.
Yeah, I'm going to rational.
Next, we have Dr. Goldberg presenting on seasonal allergies.
Great, thank you. Evening, everyone, and thank you everyone on Zoom for attending. So I was asked by the powers that be, Ms. Ford in the back, to talk a little bit about dry eye. Even though this might be a sister of allergy, we'll kind of throw it in too. Because a lot has happened in dry eye in terms of management and therapies, and I'm going to dive a little bit into it, speak to it, and happy to answer any questions after the talks. So I'm going to give you an update on the pathophysiology and subtypes of dry eye disease. This is the group I'm with. We have Dr. Jake Kubian on the right, Dr. Mythan, Dr. Barry Walston, Cindy Wild, and myself. Who's missing from this is also Isabel Duong. And we've been in practice now since '79 with Walston. So what is our understanding? Well, dry eye today versus 20 years ago. 20 years ago, we identified that dry eye wasn't just a lack of moisture on the eye. There's actually an inflammation process going on. How do we know? And we do know it also affects 30 million Americans. We know because in the published literature, Stern showed us, this is in a dog biopsy of their lacrimal gland. The lacrimal gland is the organ of the body that makes tears. It sits in the orbit above the eye. We identified all these little black dots. These are white blood cells that were attacking healthy lymphatic tissue. So we went back and looked in humans using a CD3 staining and also found these. So what we know is that inflammation's been there. Fortunately, after 20 years, we've learned that it's a chronic progressive disease. We now have treatments to the underlying cause of the disease, not just palliative care. And we know dry eye may not just be abnormal quality of tears, but quantity. And the other thing I would say is a lot of people come in and they say, well, doc, I don't have dry eye, I have wet eyes. And I say, no, my friend, you have dry eyes. Your tear film is crumbling. That's why you think your eyes water. So back in my medical school days, which I know wasn't that long ago, but it's starting to feel like it may have been a little while ago, the understanding was tear film was just made of these couple of things. You've got some oil lipid layer up here, some soluble proteins, mucus, Here's your epithelium of your cornea and a glycocalyx membrane. It was still a pretty complex understanding at the time, but little did we know, this is how we look at tears now. There's hundreds of things in it. Some of the things we haven't even discovered. There's a complex mixture of proteins, mucus, and electrolytes, antimicrobial proteins, growth factors that suppress inflammation, mucus secreted by goblet cells, electrolytes, and in dry eye, guess what? You're down some of these proteins. You don't have the right growth factors. There's a cytokine storm going on in your eye. Mucus is down. Enzymes that digest things are activated. And electrolytes are elevated, creating a more salty tear and causing it to crumble. So what's going on? How does this happen? Well, when the eye gets stressed, when we first have that, what we call de-escalating stress up here, this activates cytokine release. Well, cytokines call in a certain white blood cell called an APC, or an activated pathogen cell. This cell will go through the blood to a lymph node, and it will then activate more white blood cells. But the type of white blood cell it activates is a special kind. We all agree, maybe we have feelings on social media. Some like it, some don't. The guys who get called in here, these are your influencers, okay? The ones who really have a lot of likes on their website and Instagram. And so they go and they come up here and they identify something's going on here, and they tell all their friends. But when they tell their friends, the signal announces to so many more white blood cells. And that's when you get thousands of white blood cells called in. And then this essentially makes your tears very hypertonic, or increases your osmolarity. So what did we have before? We have first-line therapy, which is lubrication drops. And you may have seen a care provider that said, hey, use these 2 to 4 times a day. This will help. And we like starting here because, these are only $30 and they're found at every shelf across the land. But there's 80 different type. And even as a dry eye specialist, I can't tell you what the difference is between a lot of them. But we recommend them at first. But now we finally do have therapies to treat the inflammation. Restasis was the first out. It came out in 2004. The trade name, or the common medical name, is cyclosporin. Cyclosporin's taken a lot by people who have organ rejection. They take it to, do well with liver transplants or lung transplants. Well, we use 0.00001%, very low dose. And it's put in a solution called Endura with Restasis. And it seems to work very well in about, let's say, 50-60% of patients. Clears white blood cells down to in about 8 to 12 weeks. We recognized there needed to be better improvement. And so CEQA came out. CEQA is a special polysaccharide mucus membrane that goes around the cyclosporin and allows better penetration. The cornea, the front of the eye, is a tricky membrane. It's hypophilic, lipophilic, hypophilic. So it has to go through a water membrane, oil membrane, then another water membrane. It's not easy for medicine to go through those 3 membranes. The mucopolysaccharide in CEQA allows that to happen. Then another molecule came out called lifitegrast, and I'll talk a little bit about that. So cyclosporin is a complex formed with cyclophilin that inhibits a certain pathway that activates T cells. That's how cyclosporin works. It clears out T cells that way. What's different about lifitegrast is some real good scientists figured out when white blood cells come to your cornea cells to try to get into the tissue to activate the inflammation, they have little hands on their molecule. They're called LFAs. And their job for the LFA is to try to connect to the little proteins on your epithelial cells, your ICAM proteins. Well, the way lifitegrast comes, it's like a little mitten. It blocks the little hands. So little white blood cells can't hold on, and they get washed away in your tear film. And that's how Xiidra works. Xiidra has maybe a little faster onset, maybe works in about 2 to 3 weeks, but we really see maximum effect in about 8 to 12 weeks. What other predisposing factors can lead to dry eye? Aging, sorry, it's true. I feel it sometimes. Menopause, allergy response, certain environmental stresses like contacts, wind, air pollution, low humidity, decreased sleep, computer use. Then if you have eye surgeries, lid surgery, LASIK, corneal transplants, cataract surgery, then even medications we tend not to think about. I have so many people who come in, they're like, my eyes are killing me, but my cardiologist just increased all my blood pressure medicines. Guess what? That's what's causing it. Another thing we don't think about, mood-altering medicines, Lexapro, Prozac, these things have effects. Even, as crazy as this sounds, artificial tears themselves. There's now, as you know, preservative-free packaged artificial tears and those with a preservative that breaks down. Some of them break down well, some don't break down as well. And these preservatives, after repetitive use, can elicit dry eye. And very allergy medicine can cause it. So just all things we have to think about for each individual case. Then there's certain autoimmune conditions that can do it. Rheumatoid, lupus, Sjogren's, which is a specific autoimmune condition that causes dry eye. Graft versus host disease, this is when you get a bone marrow transplant, and the bone marrow from the new person thinks that your own body is a germ. So you get a massive inflammatory system. This can lead to dry eye. So there are all these inflammatory molecules get secreted into the tear film and exacerbate it. So you sort of have this cycle that we're constantly trying to monitor and battle. And dry eye can really affect it, any leg of this cycle, to cause the signs and symptoms. Another thing we don't think about is the lid. We're sitting right there by the eye. The lid's job, our beautiful eyelashes, are nothing more than wicks to make sure the oil that comes out of our eyelid properly hits into a mist in front of our eye and lands into our tear film. But if bacteria overgrowths in this area, certain lipases or bacteria proteins are secreted, and this causes issues with the oil. Another thing that's kind of crazy or gross to think about, but maybe very prominent and maybe real, is there's a certain mite that lives on humans called Demodex, and we maybe have been underdiagnosing it, and something we need to treat. Fortunately, I'm going to show and introduce you a new dog, tick, and flea medicine came out that we use in humans, and we're seeing some great signs from it. Crazy, right? So this is kind of what tears look like when they get broken down by bacterial lipase, kind of foamy, they just don't behave as right. And so you see evaporation happen faster. It's from abnormal lipid layers, and also the bacteria can affect the goblet cell. And this leads to the chronic ocular surface inflammation. So how do we treat blepharitis when it's bacteria? Well, obviously we first try with like lid scrub pads. Some people maybe have used baby shampoo at home. Fortunately, a few years ago, a few companies came out with what's called hydrochlorous acid, which is the enzyme our own white blood cells use to digest bacteria. And they put it in this lovely little bottle. And the company I use most is called Avenova, and people spray it on their eyelids, or rub it on their eyelids. And they find this is very effective at controlling the dandruff and the blepharitis inflammation there. But if that's not working and we need more, obviously we go to medication. And we use antibiotic and steroid combinations, and they work great. But then, as I joke, maybe we haven't been identifying Demodex as much as we should. You know, it's tough to think about. This little guy, you're not going to see him crawling around here. He's under the skin. He's microscopic. And people say, oh, well, doctor, can't you pull my eyelash out and go look in your magic microscope in the back? Maybe I'm not going to see it, because those little guys, they hold on. So when I pull the eyelash out, they don't always come out. But fortunately, this medicine got FDA approval about 1.5 years ago. It's called Xdemvy, or Lotenlerner. And it is a dog medicine that is working very well in humans. Take it twice a day for 6 weeks. Now, what if you need instant relief? What if you have a dry eye episode and it's not time to do your twice-a-day medication? Fortunately, there's been a few therapies to elicit a tear, and it's kind of interesting. You probably don't realize you've actually hit this mechanism yourself at home. If you ever have had really spicy mustard or spicy food or even wasabi, we've all had that feeling, right, where we have just a little too much and we go, whoo, and you feel it in your nose. What you're doing is you're hitting a certain branch of the cranial nerve 5, the trigeminal branch, that goes back and it triggers in a brainstem nucleus that elicits a signal on the seventh cranial nerve back to the lacrimal gland, back to the goblet cells, back to the meibomian glands to make tears. So if you think you're dry eye and you don't have this new nasal spray called Travai around, maybe grab some wasabi and you'll make some tears. So that could work. So there's a lot of things going on that can lead to dry eye. And each case is unique, and we have to kind of struggle and figure out which one's going on. But we eventually get there, and we can really help a lot of people. There are a few masqueraders we have to think about out there, and these are just some that we think about, just so you know. But at the end of the day, don't give up. I know dry eye can be very frustrating from some people, and I'm happy to answer any questions at the end of the talk. Thank you so much.
All right. Thank you so much, Dr. Goldberg. That was wonderful perspective. I'm really excited about the next topic, which is going into drug allergies. I'm going to kick off this talk by talking about the basics, then I'm going to hand it off to Dr. McKinnell, who will dive right into some of the things that are really going to impact your life if you have a penicillin allergy or if you know someone that does. So just like the drug, or just like the food allergies that were mentioned by Kristen, or some of the inflammatory responses that were mentioned by Dr. Goldberg, your body responds to a drug allergy kind of like food, in that it'll recognize that this is not supposed to be there and then attack it, and then it'll have an overzealous response. And sometimes that can be very violent, and then it causes a lot of problems. So this is a very complex picture, but essentially when you look at the picture and you zoom in on this portion over here, it's just looking at that foreign agent that's being introduced to the body, and then various immune cells, namely T cells and B cells, then come to the agent and help to implement some action by the body to get rid of the foreign agents that they've identified. Sometimes what will happen is they'll cause a massive, widespread systemic response, and it can result in some of these side effects listed here to the right: urticaria, angioedema, bronchospasms. Basically, various areas of your body will become inflamed. Your skin, your airway, and other areas that can affect your nose, lips, throat, and so forth. So there are reasons why some people may be more prone to drug allergies than others. Namely, if there's anything based on your genetic makeup that prevents you from breaking down medications as well, it may allow for the drug to persist, and then other things to attach to the drug where the body would respond either violently or, as we wouldn't expect. The other thing is that some drugs specifically are more prone to causing a reaction. I'm just going to touch on this just briefly, but then Dr. McKinnell will definitely dive into this. But sometimes what will happen is the drug will get introduced to the body, and then the body will form what's called a hapten. It just interacts with the drug itself. And then that hapten formation then translates to an agent where the body is not happy about seeing it, and then there's just this massive response. And then lastly, I just wanted to kind of group drug allergies as an immune response, and then that immune response will happen in two ways, right? One, it can be a very serious response. That's type 1 and type 2. So if you hear those things said by your care provider, do pay attention. Type 1 and type 2 are very dangerous drug allergy responses, allergy responses in general. That's how we would classify it. Whereas type 3 and 4, not as dangerous, sometimes can be in some rare exceptions, but typically a lot more delayed, right? And then more full body response. So think things that would impact like your skin, joints, cause some mild swelling, even cause a fever. Timing is always different in any either the type 1 and type 2 or type 3 and type 4, But whenever it's delayed, think type 2 or type 3. Type 2 is very rare, and it does depend on the dose of the medication, the type of medication, and how well your body is clearing it. But type 3 is the typical one that you would see as a delayed reaction, where you eat something, ingest something, are exposed to a drug, and then maybe a day later you'll have a full body response where it shows up on your skin or tissue or as a fever. So this is an example of a very rare allergic reaction. It's a toxic epidermal necrolysis, and basically your skin is falling off in this picture. So it's a little bit gruesome. So if you're having dinner, I'm sorry. But it just to showcase that, even those type 4 reactions are generally much milder, it can, in some rare instances, also cause reactions like this. So that said, I wanted to bring Dr. McKinnell to the podium to really dive into penicillin allergies and get into it. And after that, we'll take some questions.
Good evening, everybody. Quick question, sort of audience participation. Is anyone in the room actually allergic to a medication? Just raise your hand. 1, 2, 3. How about allergic to a food? 1, 2, 3, 4. Okay. How many people in the room have a food they don't like? Me, I don't like sliced cheese. Right? Like, it makes me nauseous. Sliced cheese, you give me cheddar, I'm like, oh, this is gross. So a lot more people are like, yeah, a few people have some food allergies. A lot more like, I don't like X, Y, and Z. I think it was George Bush that didn't like broccoli or Brussels sprouts. So something, right? Yeah. So, excuse me. He wasn't allergic to it. He just didn't like it. So I want to talk about a penicillin allergy. And I want you to think about it in terms of a food allergy versus just something I don't like. So a penicillin allergy is when the body sees the drug penicillin and sees it as a threat. It's kind of like my dad has a food allergy to peanuts. You give my dad a peanut, and all of a sudden the world explodes. And he's truly allergic. His face will swell. Excuse me. His face will swell. His tongue gets big. He talks a little funny, actually, when it happens, so it's a little scary. His throat will actually go on to close, and he carries an EpiPen, right? So you guys have heard this. This is kind of like, oh, I understand the concept of a food allergy. And if anyone's ever seen this, it is actually quite scary. When this goes on, a patient's blood pressure can drop, and that person can die. Mm-hmm. So for those of you that raised your hand that said, oh yeah, I'm allergic to a medication, I want you all to hear that when you say that, this is what I think you mean. Mm-hmm. But if you say I have a penicillin allergy, this is what I think you mean. Now, the reality is that 10% of the US population will report a penicillin allergy, but far less than 1% of the whole population is truly allergic. Remember, it's kind of like my dad being allergic to peanuts and me just not liking cheese. So if you're really truly allergic, that's really what we're driving at. So why do so many people say that they're allergic to penicillin? Like, where is that coming from? So the number one here is that if you look at how we used to make penicillin, it was a disaster. I like to brew beer, and I probably brew beer in a cleaner fashion than they used to make penicillin. Like, it's a disaster. And what would happen is, because they didn't have good manufacturing processes, they developed all of these haptens. Do you remember that Felix had mentioned that funky term, hapten? So the old penicillin, when you'd hang it, it looked brown. And they used to actually call it Mississippi mud because it was made in such a terrible fashion. So old school penicillin was a disaster. And so there's far more reactions, not to the penicillin, but the other schlock that was in the bag. So there's a whole bunch of folklore here. And this is one of my favorites, is that a patient will say, well, my brother's allergic to penicillin, so I am too, right? And I'm like, no. You can, if you eat, like, it doesn't work that way. And then recently, I had to write this one down because I thought it was hysterical. My mother said I was allergic. The patient was 85 at the time. He had a whole bunch of penicillin-like medications. Actually had penicillin in the hospital earlier. And I was like, yes, sir, you're not allergic to penicillin. You're fine. And then there's another one here, which is like, oh, I had diarrhea after taking Augmentin. And this is much more on the, like, I don't like cheese side of things, because penicillin causes a ton of side effects. And this is penicillin, Augmentin, ampicillin, the whole family of drugs can do this. You can get diarrhea. You can get a rash. You can get foggy-headed or loopy. It can cause a yeast infection. It can cause you to vomit. Rarely seizures. You can get some red skin, low platelets, other reactions. So I want to ask this question again. How many people in the room are truly allergic to a medication? One. What you're seeing here is the question before is lots of people reported it, and it's really understanding that difference that we're driving at. And so why do we care? If you tell me that you're allergic to penicillin, I won't give it to you because I'm thinking, oh, this drug could actually kill you. Now, the implications here are that if I don't use penicillin, I have to choose something else, and those alternatives aren't as good. So I may use a less effective antibiotic. I may use a more toxic antibiotic. I may develop resistance. From a healthcare systems perspective, probably more expensive, may result in longer hospital stays, or may increase mortality. And there's really, really good data here. So surgical prophylaxis, anytime you're going to have a surgery done, not any, the vast majority, we're going to give you antibiotics to prevent an infection after a surgery. How many folks have had surgery here? Lots of people. You know, how many folks got antibiotics before the surgery? Yeah, whole lot, bro. Exactly. So if you tell me you're penicillin allergic, and I'm like, oh, well, I'll give you clindamycin instead. That's a very common switch. You have a 3 times higher rate of developing an infection from your surgery. So I've taken a really big gamble moving you away from penicillin because you've told me you're penicillin allergic. So that's a real challenge for us. Now, I'm an infectious disease doctor. So I like to describe myself as a good doctor to have if you need me, but not a good doctor to need, right? If you really are sick in the hospital and you have septic shock, I'm there for you. Trust me, I'll be right there. But my initial choice of antibiotics is crucial. It's really critical that I get the right drug to you right away because you're sick, you're in the intensive care unit. If you've told me you're penicillin allergic, well, now all of a sudden it's like I'm fighting with one hand tied behind my back because you've taken a mainstay of treatment away from me. So that really is a major, major worry. Now, how do we deal with this? How do we say, you know, what's the story if am I really allergic to penicillin or not? But again, that initial distinction, you've got to be really clear. So talk to your doctor. I will have this conversation very frequently in the hospital, and I want you guys to be very clear. If you think you have an allergy to a medication, well, what happened? Did you go through that whole facial swelling? You know, did you have what we call a scar reaction where your skin melts off? Like, those are terrible things. Tell me that, right? And I will never use that medication. But if you're like, oh yeah, I had a little nausea after I had Augmentin or a little diarrhea after I had Augmentin, well, okay, how bad was that? I had 3 loose bowel movements. Okay, like, if it's going to save your life, maybe I should just give the medication. The second one is, when did this happen relative to when the medication was given? My favorite on this one was, I had nausea and vomiting before I was given the Augmentin, so therefore I'm allergic. I'm like, no, sir, no, that's not how that works. But these are real things that people tell you, and you're like, no, we have to address this, because again, once you say you're penicillin allergic, if you're unconscious in my ICU, I will have to avoid those medications. How long ago was the event? The history of the 85-year-old that said, I had an allergic reaction when I was a kid. Okay, well, that was decades ago. In fact, we know that the vast majority of penicillin allergies that are more than 10 years old go away. That's even in patients with full anaphylactic type reactions. Now, granted, there's a whole process that I would have to go through before I went there, but that's a major change. And we also know that if you had an anaphylactic type reaction to penicillin or ampicillin, you might not to other drugs in the class. And then how are you treated? If your doctor said, yeah, good luck, Johnny, you'll be fine, versus admitting you to the ICU and intubating you, those are different sort of risk profiles to your medication intolerance versus allergy. Again, just to get you thinking, do you have a peanut allergy like my dad, or do you just hate cheese? That's kind of what we're talking about here. So if you had anaphylaxis, but there's some questions, sometimes we'll actually go through and do a penicillin skin test. That's actually done by our allergists. There's a number of allergists in the area that will do that. And so we refer people out for penicillin allergy testing. But I'll tell you, we do this in the hospital frequently. And I'll tell you that the vast majority of patients, when I've actually taken a history from them and understood what the issue is, I'll either give them an oral dose or just a 10% test dose. We call it like a baby dose, and see if the patient will react or not. And the success rate here has been astronomical, because the majority of people that say they're penicillin allergic, when you actually talk to them about it, really aren't penicillin allergic. And that's really a concept that gets missed, but it's really important that you understand that for when you hit the healthcare system. So what do you do if you, quote unquote, passed a penicillin allergy test? You've been telling your doctors and your families for decades, I'm allergic to penicillin, I'm allergic to penicillin. Well, you really need to change that. There's a whole process of undoing all of that damage. So the first one is tell everyone. And by that, I mean tell your family, tell your loved ones, your spouse, your kids, your cousins, everyone, to be like, hey, I don't have a penicillin allergy anymore. That was a mistake. That's really something important, because if you come to my intensive care unit and I can't talk to you, hopefully I can talk to your loved one who can say, yeah, no, that's not a real allergy. He's not allergic to that medication. The pharmacy. I know here in our hospital, I tell Felix, and your whole allergy history gets scrubbed from our pharmacy data. But it doesn't get scrubbed from CVS or Walgreens or wherever else you've gotten your medication. So tell your pharmacist, because if I prescribe you amoxicillin and CVS has you allergic to penicillin, I'll get a phone call, right? That doesn't work. So I do want to be able to address that. Tell your doctor, tell your primary care doctor. So it's in their medical record. Tell your hospital doctor. So it's in our medical record. And tell your hospital. This is, for me as a hospital-based physician, as soon as you hit the ER, as soon as you want to know, be like, yep, if you have a real allergy, tell us, because I don't want to give you a medication that's going to hurt you. But equally, if you know this history was there and it was incorrect, make that one of the first things you say. Hey, 10 years ago, someone thought I had a penicillin allergy, but that's not actually true. I want to let you know how much I appreciate you guys coming out today. This is super helpful. I love sharing stuff about infectious disease. I'd like to say I'm really impressed that we had a dietitian that was arguing for us to eat cake. So a round of applause for our dietitian over there. And we had an ophthalmologist that's using dog tick medication on eyes, which I think is also fantastic. I think I walk away from this group of lectures with lots of information. I really want you all to know that we're here as a resource. So we have a whole panel of folks up here. We are more than happy to take any questions or thoughts or concerns. I will say up front, if you're like, oh, Dr. McKinnell, can I talk to you about my amoxicillin allergy? Let's grab me after the lecture, because we get into some protected health information there. But other general questions, we're happy to talk about. So there's a microphone in the center and a microphone over there, and a round of applause for our colleagues.
And if there's anyone on Zoom, those questions can be put into the chat, and then Mitchell will help us to get that out.
Are we taking it right now?
We're fielding questions, and I'll invite Dr. McKinnell to come back to the if you can stay there. If you want to stay there, he's fine. Yeah.
Yeah, that's why.
We have mics over here on the left, and then a mic here in the middle.
So I have a question. Can allergies be cured? Is there a cure? Is there a vaccine for that?
I'll take a shot at that. So with respect to treatment of allergies, there are a few medications out there, not very well known, to be used to abate an allergy that's very severe, as in you're going to be able to take in and ingest something like a small 1 gram of that material. There's some drugs out there that specifically address peanut allergies. And then recently in January of this year, they approved an old drug, Xolair, to be used for milk allergies. So it's not an all lost cause, but there is no specific cure or like a vaccine that you can use.
So another sort of different approach here is maybe it's the country doctor method of solving this problem, which is there are circumstances where I absolutely have to give penicillin, where it is legitimately either the only treatment or the best treatment for whatever your infection may be. And so the way we do that is we start with giving you a very, very small dose of penicillin, and we watch your reaction. And then later on, we give you a little bit more, and a little bit more, and a little bit more, and a little bit more. And eventually, you're able to tolerate a full dose. For those of you who watch The Princess Bride, it's like the guy who drinks a little bit of poison and eventually is intolerant of poison. But that's the idea. You take a little bit more, and a little bit more, and a little bit more. And that's actually been also shown to work for peanut allergies. So there's a whole protocol for how you can desensitize yourself to peanut allergies. But the problem is you have to take it every day. So for penicillin, for example, you're no longer allergic while I'm treating you, but the instant I stop, you could have an anaphylactic reaction again the next time. So you're never cured, but there are ways where we can kind of get around this. And then with the peanut allergy thing, for kids and others, they've thought about sort of, staying on this, but you have to eat like 2 handfuls of peanuts a day just to stay not allergic anymore. So it's doable, but challenging.
Okay.
Peanuts.
Well, we have a question on Zoom. Was there ever a discussion about COVID impacting pre-existing allergies?
I'm going to interpret that as COVID affecting pre-existing allergies. There is I would say a mixed literature, and I will probably punt that. One of the big challenges there is that COVID itself can cause pretty significant changes to the inflammatory cascade of the body. So there's all sorts of long COVID impacts, but I wouldn't want to comment on allergies that change with COVID. It's a bit of a murky field.
Okay, so I'm one of those who was told as a baby I was allergic to penicillin. So I had a high fever and I don't know what else happened, but I've always written on my medical forms allergic to penicillin as a baby. So is the recommendation, and that was a few decades ago. So is the recommendation to be tested now to see if that's still true, or just to wait and maybe try it sometime and get that baby dose? What did you say?
Is anyone around that was there when it happened?
Oh, Mom was gone.
Mom's gone. Mm-hmm. So I would refer you to one of the allergists. Personally, I use Dean Chang quite a bit. And I would get a penicillin skin test. And that would look to see what kind of a reaction you're going to have. And if that skin test is negative, oftentimes he can just go ahead and give you an oral dose in the office. And if you pass that oral dose with no reaction, you're free and clear. Now, if they do that skin test and your arm lights up like a Christmas tree, well, we're done, right? Then you clearly do have a real allergy, and I'd be anxious about doing it. But I would absolutely make that appointment and get it done now, because maybe you don't need a surgery this year or next year or the next decade, but you're absolutely the right person to get that whole process done. And your primary care physician can refer it to whomever they want, but I would absolutely knock that one out.
Let's see, Ms. Hung, when you mentioned one of the possible allergies is to tree nuts. And now, maybe I'm wrong, but I thought peanuts were ground nuts. Are there other kind of nuts that aren't, people don't get allergic to?
The power button, yeah.
Yeah.
Hold it down, and it'll turn green.
Back.
Almost like, is that? Start, try it.
Sure.
Testing. There you go.
Yeah.
I think when it comes to nut allergies, there's so many different varieties of how that can present. The most common is to the peanuts, but there's some people who are allergic to peanuts but can tolerate hazelnuts and can tolerate walnuts or different varieties. So some of the proteins are like very similar, but just a little bit different. So even as doctor is mentioning, in terms of like when they're training children to be so allergic to peanuts, sometimes they'll use these biosimilar proteins from other nuts to kind of help their body get used to it and not react so strongly to that particular nut. So can be very similar, but sometimes a person will react to one and not the other.
Is sulfa considered an allergy or a side effect if you react every time you have a medication that has sulfa in it, which most medications do?
So, with regards to sulfa, I think that's kind of a topic we can really dive into, just kind of like penicillin allergies. If you have a drug allergy that has sulfa in it, I would name the specific drug, because it's sulfa versus sulfonamide. They're a little bit different and classified as different.
Well, what if you happen to be someone who just, no matter what derivative of sulfa is in there, you have a reaction?
I would still advise naming the specific drug and then actually saying what had happened. You know, when you took the particular sulfa-containing antibiotic, what was your reaction? At what time did you react after taking it?
Well, like for an example, even Tylenol and ibuprofen have sulfa in it, and he still reacts to that too.
Right. So you're talking about the inactive ingredients?
Yes.
Yes. Yeah. So similar to what Kristen had said about the labels, the label reading with medications is actually just as important, because not only should you be looking at the active ingredients, but there are label requirements that lists out all of the inactive ingredients for that particular medication.
Right, because the sulfa derivative can be way down in the rare reactions to a particular medication.
Right, right. And again, for the sulfa allergy or for any of the drug allergies, name the drug, tell everybody what happened, and the specific, and they call it a clinical phenotype, the specific type of reaction you had.
Okay.
Because say, again, if you had a vomiting episode, and that might not look like an allergy to us, it'll look more like a side effect. Another severe one could be like seizures, right?
Okay.
Right? That's a severe side effect. Right. And so we would also be concerned about that, but we wouldn't classify it as an allergy. It's a side effect.
Okay.
Yeah.
All right, thank you.
And allergies cause dry eye.
Long story, yes. Basically, think of it as, if your eyes are, as we age, we all get more dry eye. So it's not so much that allergies cause dry eye as your pre-existing condition of having dry eye makes everything annoy your eyes more. Wind, dust, allergens. So usually the dry eye is there, and then that's why the allergen that maybe didn't used to bother you does now, and that's why you're experiencing the allergy.
What if you only have dry eye really seldom? Does that mean it's...
Then you have mild dry eye. What it is that for the majority of the time, your tear film is able to keep itself together. Your tears maybe aren't breaking up as quickly as other people. The saltiness of your tear, your osmolarity level is probably not way high, but it's not perfect either. And so that's why most of the times you do fine. But the other tricky component of this is in people who do have dry eye, what they also experience is what's called neurotrophic corneas, where the nerve endings in the cornea start to abate. It's sort of like your skin gets chapped on your eye. So it doesn't happen overnight. It's a chronic process. So you may not think you're dry because your nerves aren't telling you you're dry. And so what we also see sometimes in surgical patients is right after a surgery like a LASIK or a cataract surgery, they seem okay right in the moment, but then just a week or two later, they really start to complain about these symptoms just because the blink reflex has been diminished because the nerve impulse has been cut to tell them to blink. So there is a lot going on, and it's like a brain teaser there a little bit.
Is there a way just to look at the eyes and see the corny and know whether this is a problem?
It'd be so great and easy if it was, right? There are certain stains we use in exams. The yellow drop is called fluorescein, and there's a green drop called lissamine green that we put on the conjunctiva. And it's so great when we say, oh, look, your eye lit up. You have dry eye. The reality is, so much of dry eye management is based on symptoms and how the patient's feeling. And that's what makes this very tricky. There's not a sign that glows on your head that says you have dry eye. Sure.
I did want to add to Dr. Goldbert's comments about allergies and dry eyes. From a pharmacy standpoint, I think Dr. Goldbert had a specific slide that showed antihistamines as one of the agents that could cause dry eyes. And so when you're taking your medications for seasonal allergies, you also have another reason for getting dry eyes. So there's a lot of cross relationship here.
To one more thing to add to that, a lot of people also don't think about nasal sprays. What do most allergy nasal sprays do, right? They cause a vasoconstriction, right? Shuts down the faucet in the nose. Well, guess what's right next to that, okay? The parts of your body that make tears for your eyes. So if you're shutting down the nose, nasal sprays are kind of like turning off the water to the house when you have a leak in the kitchen. It creates an effect throughout the entire, region. So just something else to think about. Yeah, you can.
Follow-up question, if you will, Dr. Goldberg. In your presentation that showed T cells and what have you,
yes,
things happening, I think you used a phrase, something about washing out the white blood cells.
Right.
And this is total neophyte talking about this, because I always thought if there was some problem, the white cells were what came in and fought disease and what have you.
You are not wrong, right? White blood cells' main job, right, is to attack germs, right? But we can also think of examples in health where white blood cells maybe aren't great, right? Like rheumatoid arthritis, inflammation, chronic diseases. Dry eye, when it really gets bad, is really no different than like a chronic inflammatory disease, kind of like, rheumatoid arthritis, right? So the problem in the eye is there's not really a germ, right, causing the irritation, but there are cytokines that get released because certain cells get damaged in dry eye, and these cytokines trigger other white blood cells to come in. So that particular slide, the anti-inflammatory medications, what they do is they either clear out the white blood cells or they block the white blood cells to get to certain parts in the eye. They have to squeeze through your cornea epithelial cells. They have to squeeze through them. But to get there, they have to take their little hands and hold on to the cells, right? Because you're constantly blinking, constantly making more fluid. And so if it's not, the perfect environment for them to be able to attack the germ, they move on.
Thank you.
Sure.
So I have a question on Zoom. What are environmental allergies?
Is that for the dry eye, or is that for just allergies in general?
I think it's allergies in general.
Yeah.
So lots of folks will talk about seasonal allergies that are mostly produced from the pollen in the air. And so I think that's usually the most common thing you're going to be exposed to in the environment that's going to trigger a robust inflammatory response. I presume the same thing's for the eye? Yeah. So it's the environmental allergies for the body when you get the runny nose and all that. You're being exposed usually to a pollen that's triggering that. And you'll see the same thing with the eye.
I think this might be for food, but in general, I'm just wondering, is there more of an occurrence of allergies in food today? I mean, I'm thinking, I grew up in the 60s and 70s, and so much of this we had never heard of. And do you attribute it partly to environmental factors, or are we just discovering more about this, or where are we at, so to speak?
Yes, definitely. I think within the past several years, there has definitely been an increase in food allergies, but also food intolerance. I think there could be a lot of reasons for this. Part of the reason I think is our like food production and the amount of processed foods and things nowadays has increased quite a bit, and a lot of people do have intolerance or even allergies to additives to foods. So that could be part of it as well. And in terms of intolerance too, a lot of that is related to digestion and like a difficulty digesting different foods. And part of that is also related to our microbiome. So like the bacteria in our guts. And I think that varies person to person, but overall also is affected highly by our diet. Our diet right now is definitely a lot lower fiber than it might have been like several years ago, with people eating a lot more processed foods, a lot less fruits and vegetables and fresh foods. So with that too, that affects how much our microbiome is able to help digest some of the foods as well. So I think all of those things could be kind of factors in why we have seen an increase, and probably also more diagnosis of allergies as well.
Okay, thank you.
I have a question on Zoom. Is it easier to treat environmental allergies with allergy immunotherapy shots than food allergies?
So with respect to treating allergies in general, easier to treat, harder to treat. I think when you're thinking about the environmental allergies, they typically appear as milder symptoms, and so they may also appear to respond or be treated easier than maybe your full-blown anaphylactic reactions. But in general, again, I think that the treatment of allergies, we have just a few narrow handful of medications that we use to address allergies, both on the front end and on the back end, either to prevent the allergy from happening or as a reaction to abate any symptoms. So there isn't really a harder or easier in my mind. It's just treating ahead of time or treating in the moment. Those are kind of how I categorize it.
Another question on Zoom. Has GMO contributed to increased food allergies?
I think that it probably has. One of the things too that just relates to like how our food is produced, and there's so many chemicals that is kind of goes into food production now that I feel like we probably still don't fully understand, in relation to like say fish. Like that is something like if you were to catch a fish and eat it right after catching it, that may not be as much of an issue, but when we catch fish and then it travels and sits out for weeks or even longer than that, and then ends up in your store and then you eat it, the certain proteins may have changed and developed in that process that then you're having an allergic reaction to. So I think that just our whole kind of food system has tended to a little bit more allergies because of that. We also had changing science in terms of when to introduce allergies. So there was or allergens. So there was a large period of time where delayed introduction was thought to reduce allergies. So people were not introducing like babies, pregnant women to these allergens. And then they discovered actually that increased food allergies later on. So now the recommendation is for the early introduction. So there's so many factors I feel like that have kind of played into it. But yeah, definitely our food processing, the way that we produce food, I think is one of those factors.
What are the common signs and symptoms of penicillin allergies?
So the scary version is kind of what I described initially during the presentation is you give the dose, all of a sudden their face gets flushed, their tongue swells, they have difficulty breathing, and you can start to lose consciousness as the blood pressure drops. So those are the ones that scare the daylights out of me. Usually we're in a hospitalized setting or in the ER, and we respond very quickly and very aggressively to those kind of reactions. So that's sort of the biggest worry. But Felix mentioned sort of type 1, type 2, type 3, and type 4 reactions, and they're quite variable. And sometimes, a true allergic response may be that your skin gets a little bit red. Nothing exciting, you just get a little bit of hives, and you want to say like, well, I can tolerate that. And now I have to be aware of that, and I'll probably work around that, but I might go ahead and treat through if I really needed that penicillin type medication in those circumstances. So the answer is it's pretty vague at the end of the day, but the one we really care about is that anaphylaxis, or if you have those blistering skin rashes that we saw the picture of before. Thank you for sharing, Felix. Yeah.
Well, if there are no more questions, we're going to end the session, and there's still cookies and coffee, and we'll hang out because these are wonderful people to talk to. But thank you again very much for attending this session hosted by Miracle of Living. Thank you again, Mary Ford, for helping to put everything together and gathering the minds. Thank you, Kristen, for showing up and giving us such a wonderful discussion about food and answering some very hard questions. Dr. Goldberg, again, thank you for coming and enlightening us and giving us new perspective on dry eyes. It was wonderful. And Dr. McKinnell, great sense of humor, warning us about all the penicillin allergies, will be available for discussion just after this. Thanks, everybody.